My name is Andrew Garza. I'm a physician assistant practicing in outpatient adult endocrinology. I've done this for about 4 years now, and during my more recent experience, I've had the ability to gain some experience and interaction with resmetirom. So today, I want to discuss the safety, monitoring, and drug-drug interactions. Regarding resmetirom, it's generally well tolerated. In the MAESTRO-NASH trial, which gave resmetirom accelerated approval for the treatment of MASH with F2 or F3 fibrosis in conjunction with diet and exercise, the most common adverse events seen in the study were defined as an increase of adverse events over 5% compared to the placebo group. These were diarrhea, nausea, pruritus, vomiting, constipation, abdominal pain, and dizziness. Diarrhea and nausea were the most common cause of treatment discontinuation, and this is what I commonly see in clinic as well from a side effect perspective. Most of the GI-related side effects are self-limiting and occur within the first 12 weeks of treatment. Worth noting, in the MAESTRO-NASH trial, around half of the patients had diarrhea at baseline, meaning that some of this was worsening of a pre-existing diarrhea or loose stool. There is the risk for hepatotoxicity. In the study, there was one patient with substantially elevated liver enzymes that resolved once treatment was discontinued. After event adjudication, it was discovered that this patient met criteria for primary biliary cholangitis, indicating a possible autoimmune origin. Worth noting, after initiation, there is a mild spike in liver function testing and transaminases, but usually that spike is less than 1.5 times the baseline. This usually occurs around week 4 and resolves around week 8. Afterwards, in continued use of the medication, the LFTs generally return to baseline and actually below what the baseline was for many patients. In terms of monitoring, it is recommended to check the liver enzymes at 3 months, 6 months, 12 months, and in regular intervals thereon. Cholelithiasis, acute cholecystitis, and gallstone pancreatitis were observed more in resmetirom than in placebo-treated patients. The exposure-adjusted incidence rate was less than 1 per 100 person years. There are some drug-to-drug interactions that you need to be made aware of. Resmetirom is a substrate for CYP2C8 and OATP1B1 and OATP1B3 transporters and is a weak CYP2C8 inhibitor. Therefore, with strong CYP2C8 inhibitors like gemfibrozil and OATP1B1 or B3 inhibitors like cyclosporine, the recommendation is to avoid concomitant use. For moderate CYP2C8 inhibitors like clopidogrel, the recommendation is to reduce the dosage. The current dosing model for resmetirom is weight-based. If the patient weighs over 100 kilograms, the starting dose will be a 100 milligram dose. If they weigh less than 100 kilograms, the starting dose will be 80 milligrams. If they are on clopidogrel, we reduce that by having patients over 100 kilograms take the 80 milligram dose and patients under 100 kilograms taking the 60 milligram dose. This is likely the only time that you will use the 60 milligram dose. There is also an interaction with statins. Therefore, there are suggestions for the maximum statin dosage. For atorvastatin, the maximum is 40 milligrams. For pravastatin, the max is 40 milligrams as well. For rosuvastatin and simvastatin, the maximum dosage is 20 milligrams. I want to thank you for your time and hope you found this helpful.